Okay, commenter number 2. Thank you.
Good afternoon. Thank you very much. My name is Stephen Martin, S-T-E-P-H-E-N, last name Martin, M-A-R-T-I-N, and I'm with Boulder Care, and I will also spell that because it is B-O-U-L-D-E-R Care. Thank you so much for this opportunity to share comments on behalf of Boulder Care. We are a Joint Commission-accredited telehealth organization caring for people with opioid and alcohol use disorders since 2017. I have served as Boulder's medical director for research, education, and quality since early 2019. After attending medical school at Harvard and residency training at Boston University, I became a family physician and addiction medicine specialist. For nearly 20 years, I have provided in-person primary care in rural Massachusetts, where I'm also a professor of family medicine and community health at UMass Chan Medical School. I came to DEA headquarters today knowing of your memorial and photographs for some of the people who have been lost to opioids, especially fentanyl. In my rural office above my desk, I have my own photos of health center patients we have lost to overdose as well. I still care for their grieving families. I begin my comments sharing this mutual respect for those we have lost with you and recognizing we are here together to find the best way forward to help everyone in need. Almost 20 years ago in 2004, I was in my residency training at South Boston Community Health Center. An internist faculty member had just begun prescribing buprenorphine, which was recently approved, and his panel maximum was 30 patients. When that number went to 29, people in the community knew about it before we did. People were desperate for this life-saving medicine, desperate, and we were essentially running a lottery for people to survive addiction to OxyContin. 20 years later, we now have a lottery for people to survive addiction to fentanyl. A major reason is that American primary care cannot take on the complexity of this type of care at the scale that is needed. The numbers speak for themselves. People can't even establish primary care, let alone access just-in-time expertise to care for this life-threatening condition. Even with the X waiver eliminated, researchers and practitioners both acknowledge this is unlikely to change the basic calculus of available treatment. If people can't access buprenorphine through primary care, what are their choices? The outcomes for naltrexone continue to be disappointing, to the point that people have voted with their feet. It is used less than 1% of the time compared with the other 2 FDA-approved medications. Access to methadone in the US is the most tightly controlled in the developed world and has its own well-described and entrenched obstacles that are doing harm. Unfortunately, they aren't likely to change in the near term. If methadone is not increasing in availability and naltrexone isn't useful, we are left with buprenorphine. As a matter of policy, if this medication isn't readily accessed in primary care, where can it come from? A relatively small number of the estimated 7.5 million Americans with opioid use disorder end up in the emergency department, where, even when they are seen for an overdose, they are prescribed buprenorphine less than 10% of the time. 20 years after the scarcity of treatment I saw in South Boston, this scarcity continues. But we are here together because there is a proven solution of telehealth. Let me tell you a bit about Boulder Care. Since the suspension of an in-person visit in March of 2020, our clinical team has conducted over 50,000 visits on secure video and engaged in 600,000 secure telecommunication touchpoints with several thousand patients. Almost 90% of our patients have Medicaid coverage, the most underserved population in substance use disorders and who have the greatest needs. Over 30% of our patients live in HRSA-designated rural areas, and the vast majority lack transportation. Despite the challenges of being in remote areas, our rural patients have parity in outcomes compared with those who are located in suburban and urban locations, as has also been found by other telehealth providers. 64% of our patients who responded to a March survey said they have significant barriers to in-person care, lacking access to transportation, a nearby health care facility that can treat substance use, or a primary care provider, or a combination of all 3. Hundreds of patients reported that they fear losing their privacy and anonymity if forced to seek services locally, particularly those residing in small towns. There is shame and humiliation associated with in-person addiction treatment, and there are related risks of losing employment, child custody, and social standing. Boulder Care is relentless about using data to improve our work, publish research, and share insights freely with others who may benefit. We are held accountable for quality care by dozens of health insurers who reimburse based on outcome metrics. Between 2021 and 2023, through grant funding by the National Institute on Drug Abuse, we conducted a prospective cohort study with our research partner, Oregon Health and Science University, reporting our findings this past June. We found that telehealth-only clinical outcomes were the same or better than treatment as usual. The study found Boulder Care's 6-month retention to be approximately 90%, 3 times the national average for office-based opioid treatment. Another analysis of our clinical outcomes found that patients who stay in care with us for 3 months have a 50% chance of staying with us for more than 2 years. Our data is consistent with a body of peer-reviewed research, including recent reports from the CDC and NIH, that indicate telehealth-only buprenorphine care is safe, effective, valuable to society in the midst of a worsening national opioid crisis. This research also finds that an in-person evaluation is not representative or a proxy for quality health care. I can understand the inclination to associate in-person with increased quality of care, but having been in healthcare for over a quarter century, there's a lot of terrible in-person care and a lot of excellent care at a distance. Having 2 warm bodies in the same room has nothing to do with safe or quality care. Everything one would want from a public policy perspective, improved equity, health, quality of life, and help for vulnerable populations, is being done with telehealth-only care. As practitioners with decades of clinical experience treating patients and prescribing controlled substances in person and through telehealth, we'd appreciate sharing some recommendations about policies that will impact our ability to provide buprenorphine treatment for adults. We echo prior comments about minimizing burden placed on patients and have ample evidence that a mandatory in-person visit of any type presents a significant barrier many patients will not overcome. We concur with sentiments that regulating clinical entity is preferable to adding requirements for patients. We caution against adding new forms of patient surveillance not supported by medical evidence or deemed necessary by the treating provider, having seen these protocols deter patients and providers for decades. Examples include prescription dosing limits, short-term prescriptions, and frequent drug tests. We ask that the DEA consider the extensive local, state, and federal oversight already in place to regulate practice standards for practitioners. Practitioners are already required to report copious information to licensing boards, state authorities, insurers, and accreditation bodies in order to practice. The DEA can make use of existing data sources for clear quality indicators and warning signs to identify and root out the potentially few bad actors. A special registration, if enacted, should not create unnecessary administrative burdens on telehealth providers with multi-state practices and avoid exacerbating existing challenges to providers. As stated by previous commenters, providers should not be required to maintain physical addresses or locations in multiple states. Lastly, telehealth prescriptions should not be labeled as or red flagged. Pharmacies, particularly certain large chains, have discriminated against and refused to fill valid prescriptions from telehealth clinicians, as described during a SAMHSA 2-day meeting last year. Any requirement to label a prescription as telehealth will further stigmatize and restrict patient access to medication. Pharmacist colleagues from around the country are allies in supporting telehealth-based care and do not see a need for such labeling. Earlier this year, we received hundreds of comments from our patients about the hardships an in-person visit would present for them or future patients. With their permission, I appreciate bringing in their patient voice to this listening session. Patient 1, to get the medication I need to live a better life, my 75-year-old mom was actually driving me and another disabled individual almost every week to our last MAT program. Not only would it be traumatic to see a new doctor I'm not familiar with, as a war veteran with PTSD and dual diagnoses, it would disrupt the continuity of treatment. Patient 2, the care I am getting at Boulder is available 24/7. I've utilized their on-call doctor in the middle of the night and can reach my peer support all week. My peer calls back within an hour. My doctor answers my messages within seconds. They've helped me live a safer, better life, helping others and living up to my potential. We should be trying to ease patients' fears and trepidation about getting clean and sober, not making it more difficult. and patient 3. I've been with Boulder going on 2 years. Suboxone care through telehealth has saved my life. My doctor is amazing. Although it is through telemedicine, we have a personal relationship, and I have an attachment to her, a real connection. She has supported me more than just through addiction, and my 8-month-old baby has her mom back. Making quality treatment accessible ensures that the right thing to do is also the easiest thing to do. The alternative, purchasing fentanyl on the street for $3 by sending one text message, should scare and inform us. We can prevent diversion and overdose by giving people an immediate link to treatment as soon as they are ready. Telehealth uniquely makes this possible. Lastly, very few healthcare interventions actually scale, maintain quality, and improve equity. Telehealth for opioid use disorder does each of these. It is truly a medical miracle, and it is the only demonstrated solution that can help this administration meet its goal of dramatically expanding quality care for opioid use disorder. We ask that you please ensure conscientious telehealth providers can continue to readily offer and expand this life-saving care as they have for the past 3 years. Thank you for your time and consideration.
If I could, just a couple of questions.
Thank you.
You so much. To clarify, and I was taking notes, but I might have missed this.
Certainly.
So you were talking about the removal of the X waiver,
Yes.
the expansion of the number of providers
Yes.
for buprenorphine. But I believe you were saying that American primary care can't take on buprenorphine, and
Yes.
I would just love to have you expand on that a little bit.
I have a textbook I'm writing. I'm very dedicated to primary care. I think it is probably the best source of care for this kind of work. In Massachusetts right now, if you're in Boston, you can't get primary care for 6 months. And that primary care is not likely to know what to do with opioid use disorder. In other settings of the country, those data are worse. If you have Medicaid, worse. If you have no insurance, worse. And again, fewer than 5% of primary care providers have an X waiver showing interest prior to the removal of the waiver. And the complexity, this is not hypertension. It really is very different. People are living with a life-threatening illness. And we have a dedicated phone number for people on Suboxone, so they can get right to a knowledgeable nurse that hour, that day, that minute. Primary care, unfortunately, just isn't built to do that these days, and I wish it were, and I hope to see it do it someday, but we don't have time. I hope that helps.
Thank you. It's very helpful. The guardrails.
Yes.
You talked a little
Please.
bit about available data, but
Yes.
it'd be helpful to have you talk a little bit about what guardrails you think should exist around telehealth prescribing.
Oh, certainly.
Yeah.
Yes, certainly. Well, I've been through the generation that came through the prescription monitoring programs, and the data that are available there are quite robust. People can tell what Steve Martin is prescribing and on any given month to any given set of people in any given location. That's a lot of information to work with. And I do think that the tracking mechanisms that are available currently can let DEA evaluate not only number of prescriptions, but also types of prescriptions and forms of buprenorphine that are prescribed. There are certainly cases where a monoproduct of buprenorphine is in somebody's interest, but I do understand the policy concern about that becoming a majority of prescriptions for any given provider.
So we had
Sorry.
we had this conversation yesterday. DEA does not have access
Oh, I
to
apologize.
many instances
Yes.
to the PDMP. And
Yes.
so I think the way to ask you to expand is would you
I would, yes, I will. I would think that a national PMP makes more sense. And I had heard that comment yesterday, I believe. The fragmented approach right now is very difficult. If I have someone in Vermont, I have to press a separate box. If I have someone and I don't know what they're counting, Massachusetts looks at gabapentin, but others don't. Again, I think because that the relative downside is relatively low, but the upside is that DEA would essentially have a passive collection of information that wouldn't require another degree of surveillance. Thank you.
Could you expand on your perspective of audio only
Yes.
and two-way?
Yes. Audio only? Yes. So Boulder, my company, does not do audio only. For good reason, I think. We're in the new terrain. We're not really sure how this will be evaluated. But I've been advocating in Massachusetts on behalf of patients for what we have in Massachusetts, which now is law to compel the use of audio-only payments. The reason is very clear. Mass General came out with a study very early on in the pandemic showing that the people who are excluded from telehealth care are predictably brown and older people if video is required. There's no data to show that video is any more helpful in any part of medicine other than neurologic conditions such as Parkinsonism. The barrier to entry with video is so difficult, and highly technical people can't get me on video and vice versa, no matter how hard we try. And it seems to me, I'm hesitant, it's almost a fetish, this idea that video adds value. It doesn't. It often detracts, unfortunately, and it detracts for people who can least afford to lose care. I hope that helps.
It does. How do you evaluate that patient? Because you mean clearly this is a
Certainly.
very difficult. OUD is a very difficult thing to assess. So how do you assess that on the audio only
No,
call?
certainly. In my experience, patients present to me the kind of patient that they think I'm looking for. And I try to dispel that as quickly as possible because I want to know who they are as a person. I don't think that's any different with video. I don't think that's any different in person and not with audio. If someone called me and said that they had a fentanyl disorder and they needed help, I would take that at face value. If someone wanted all the constraints and difficulties of getting buprenorphine and taking it, there are far easier things that they could do to in their lives. But I think I've been finding that these diagnoses are less difficult to make when someone calls and said, I overdosed and was in the ER yesterday, can I get some help? And that hearing that over the phone would work just as well. Thank you. Thank you very much.
Okay. Commenter number 3.